May I go on to the next session, please? A 1 hour session, case-based discussion, sudden deterioration of patient condition during a planned PTCA. All feel very cozy, it's a matter of my left-hand job, and then what happens? May I call upon the stage the chairpersons, Dr. R.S. Joshi, sir, Dr. Shubhanand Rai, Dr. Dipankar Mukhopadhyay, Dr. M.S. Hiramat, and Dr. Shuni Banerjee, please. And as moderators, may I call upon Dr. B.P. Pandey and Dr. Shankar Mondol, please. Dr. Devdatta Bhattacharya, would you mind to come upon, though you are a speaker, but you please be moderator for the other 3 talks as well. You can bring your tea over here.
Request everyone to keep their presentation 12 minutes and then we can have a good discussion. Dr. Devdatta, you are the first presenter. Yeah, you are the first presenter.
I'm the first presenter.
Oh, you are the first. Okay, Dr. Hiramat is going to speak.
So good afternoon. Actually, when we talk of rotablation, I'm going to talk to you about rotablation and how do you zoom this? You know, the whole idea of, sorry, I think we got the wrong talk. Whole idea of doing rotablation is to sort of make the lesion soft so that ultimately we get a very good stent expansion. And from this angle, we do rota. Like in this first case of ours, you can see a very hard lesion. You can see we are trying to, this was done outside and you can see the balloon is not expanding at all. And at this stage, the patient was shifted to our lab. So we do a rota and see in the last frame, you can see the balloon expanding very easily. So this is the whole idea of doing rotablation so that an expansion can come up. And this particular case, we did culottes to get this kind of result. You can see the diagonal is a very, very big vessel compared to LAD, and it was really important to do rota to get a perfect expansion on the LAD. And you sometimes run into this kind of situations where you have calcification, bifurcation, a very important side branch. So what we do is we do a rota to the LAD. And then after doing a rota, we put a wire to the diagonal, and the diagonal is addressed with a flex tom, which is like cutting balloon modification. So the purpose or intent is like cutting balloon. So the 2 vessels are addressed differently when we are doing a rota, and then we can have a good result of this nature on this case. So this is actually bifurcation, 1 rota, 1 with flex tom, and a good result. In this particular case, this is a CTO, so getting a rota wire is many times very difficult. But the reason to do rota was actually we were unable to advance the support balloon on this wire. So the wire has crossed, but the whole thing comes back when you use Guidezilla to support. Despite Guidezilla, this is not going. So we bring in a Corsair. The Corsair also fails to cross. And then we leave the Corsair here, bring the rota wire down, and do a burring. So this is the purpose of this rota, that wire is not, balloon is not going, wire is going, and despite all our efforts, we are not able to cross, and then you do a rota, and then you get a result of this nature. So rota comes very, very useful in many of these settings. In this case, again, we have a CTO LED, balloon not going. So we do a rota, a fairly similar technique as before, through Corsair, a rota wire, do burr, and then a final result of this nature to get a flow going. But rota may have its own negatives. So this is what has happened here, that we have come in, I'll show you the movie again. So this is a calcified lesion, as you can see, an extensive calcium. We have EBU 7 rota wire, and then we come with a 1.5 burr, which is not moving forward. So this is a stuck rota. Fortunately, when Sunip gave me this topic, I had only one such case, that too pretty old, and this is the only run that I could show. So you can see in an effort to pull back the rota, you can actually go on the pedal mode, and then you pull it back. But as we are trying to do that, the guide catheter has got sucked in pretty deep, almost to the lesion. But since it was already there, we took help of that guide catheter position, sort of stabilized and pulled the rota burr back. So this was with 1.5. Then we came back with a 1.25 burr, then upgraded to 1.5 burr, and this is the final result we got on this case. So stuck rota is obviously not a good news. You have to go onto the pedal mode and then get it back. Be very careful. The guide catheter can easily get sucked in and can dissect the left main. But you have to be very, very gentle and give a gradual backward traction and get it out. In this particular case, we have another complication related to rota, and that is a broken rota wire into the distality. So again, very difficult CTO. We have crossed it with Fielder XT. There is a microcatheter switch to a Corsair, and then the rota wire has come in. You do burring the way you want or the way you normally do. This is 1.5 burr, and this is the final result. Actually, you can see we have a regular wire, but in addition, fractured rota wire lying here. So this is the rota wire which is fractured. At what stage it got snapped, we have no clue. But at least it is radio opaque that you can see it. But I'm sure if it was not radio opaque, you would not even see it. We had no way to retrieve it. We have actually finished stenting when we realized it, but this is left as it is since there was no way to retrieve it. So this is actually one way in which you can complicate your case on rota. So when we have a heavily calcified lesion, never use an oversized balloon and try to inflate very vigorously. Many times the waste is not going, so there is the intent to sort of use higher and higher pressure. You may in fact downsize the balloon if you're facing such a situation and you don't have any kind of debulking strategy. You just cannot crack a very hard lesion with a simple balloon. You'll only perforate the vessel. So in these kind of situations, you need to use a rotablator. And if you do rotablator, you can march ahead. Now, does a rotablator make things safe always? I mean, this is a question. Many of us believe that once you use rota, you can inflate the stent. Even with a lower pressure, you can get a good expansion. But there are some who believe that rotablator can weaken the vessel also. I'm not the one who believes this, but this is one such case where we have done a rota, then a stenting, and then used a conventional non-compliant balloon pressures, something like 1820. And luckily the perforation is into the ventricle. So nothing happened to the patient. Patient was very, very stable. We waited almost half hour into the cath lab, and this kind of perforations will not trouble you. So these are some of the ways in which you can debulk the lesion and sort of make things easy. I have some more cases. I have little time.
Yeah, please.
Okay. So, so here again you can see you have done a rotablation, and then you do a balloon dilatation, and you can again see a perforation of this nature. In this case, we just kept the balloon inflated for a long time, and we of course reversed with protamine, and the lesion sort of healed itself. So these are some of the shortcomings which can happen. So this was again a rota done to proximal LAD and left main. We stented, first stent was here in the proximal LAD. The intent was to put one more stent at the back. But when we deployed this and went high pressure, after pulling the balloon back, we had this perforation. We had a lot of things to do in this area, so this particular patient went for surgery after this perforation. So I would almost like to believe that rota is reasonable to avoid perforation, but it's not zero. I think even after rota, you can occasionally get perforation. The big thing that we worry about is no flow, slow flow kind of situation after rota. And this is one scene after rota. You can see the patient complained of chest pain. I would imagine this is a slow flow which is minimalistic. Like we are still seeing a flow, there was no panic, and we could go ahead and finish the case. Typically you would use a lot of dilators at the microvascular level, like SNP, adenosine, and all those things, and it would work. But we all know that rota done in a correct indication works very well. But rota with a recent instability, like possible thrombus, etc., could be a big issue. In this previous case, we are able to put in stents, and you can see the microcirculation is very well preserved, and patient did very well, though immediately after rota, he had some kind of slow flow situation. Now see this, this was actually a densely calcified left main. You can also see the calcium sort of extends into the proximal LAD all the way to the bifurcation with the first diagonal. This patient was actually admitted about 15 days back with non-STEMI. We put her on a low molecular weight almost for 8 days. We were also worried that apart from calcium, there could be a thrombus in that area. And when we do a rota 15 days later, having a good weight, believing that the thrombus may have cleared, patient was of course getting repeated episodes of angina in the intervening period, though she was at home. We run into this kind of situation after rota, absolutely no flow. So this is a time when there is a big panic. Patient was getting excruciating pain. Luckily, hemodynamically, she was stable. But we used all the drugs into the coronary circulation. In fact, finally, we put aspiration, thrombus aspiration catheter. Through the thrombus aspiration catheter, we actually gave 1 ml of diluted adrenaline. And then we finally ended up with this kind of result. But you can see we have very few microcirculation preserved. You have a good result on the main branch with so much struggle, but I think we have lost a lot of side branches on this case. Patient had to go on ventilator, balloon pump, etc. So whenever you're doing rota, make sure that you are staying away from thrombus in the recent times. Otherwise, we could have these kind of situations. I think I finished my rota, Sunip. I'll stop.
Thank you. Thank you, sir. Thank you.
Thank you.
Give him a big hand. So if we have some time, we'll keep the discussion at the end. Dr. Bhattacharya, you can come for your presentation on this dais.
Okay.
Sir, please join us here so that we can have some discussion. You can keep your questions ready and we'll quickly answer to those things. It will be better.
Can I have my presentation?
Yeah, it's here if you can come.
There?
It will be better, yeah. So this is all on sudden unexpected thing happening in the cath lab.
Thank you. Thank you. I thank the organizers for asking me to give this lecture. So this is a silly little case, and so we have a patient who is a 58 years male who is non-diabetic, chest pain at rest, diffuse T-wave inversion in the precordial leads, normal echo but hypokinetic septum, normal size cavity, sorry, hypokinetic septum, epico-anterior wall, so we are expecting LAD. So other walls contracting normally. And angiographic findings are, the LMC is normal, the proximal LAD shows a 90% discrete stenosis. The D1 ostium, which appeared to be a small calcifier vessel, had a ostial stenosis. The circumflex was dominant. And the marginal and the other segments were normal, and the EF was 55%. So take a look at the angiogram. And this was a patient that we had taken late in the day, and we were a little tired, and it was not our best day. So we made a number of mistakes. Anyway, keep looking. So this patient, as soon as we did the angiogram, he had a lot of chest pain, and there were ECG changes, and his blood pressure was labile. So we had to decide. So take a look at the angiogram, and keep a look on the diagonal. You can see the circ is dominant. So we passed a wire into the LAD, and then we tried to pass a wire into the diagonal, and we were having some trouble. And the patient was having chest pain. So we thought that we would just quickly do the LAD, and that will solve matters for us. So we took a balloon and we dilated the LAD. And after that, the patient kept having more chest pain. So we thought that we'll quickly stent the LAD without realizing that the diagonal was not looking too good. And we stented the LAD. And now the LAD looks very good, but you can see that the diagonal is occluded totally. So Sunip, you asked for a side branch occlusion, so this is the best one I could get. It is, these are technical errors. So what we did was we post-dilated the stent, and then we recrossed. Sorry. And we recrossed, and we then opened up the strut with a 1.5 balloon. And now you can see that if you remember the diagonal from the beginning, the diagonal is not an inconsequential vessel. So we underestimated the diagonal totally because the LAD, proximal LAD, was a very tight lesion, and the flow into the diagonal was hampered. In addition to the LAD lesion, there was an ostial lesion. So the diagonal looked small, but the diagonal is not actually a small artery. And there is a significant area of distribution as well. So what is the analysis? Well, my analysis is we made a number of mistakes. We tried to wire the diagonal after wiring the LAD and faced some difficulties, and we thought we would cut it short. We thought the diagonal was small and insignificant. And as the patient was having severe chest pain, we thought we would fix the LAD quickly and not waste time in wiring the diagonal. So after POVA to the LAD, the chest pain didn't improve, and we rushed to fix the LAD without noticing that the diagonal flow was now significantly hampered. And after the stenting, only after stenting the LAD, we realized that the chest pain will not be relieved unless we fix the diagonal, which we did. So the diagonal, so when we analyzed the case later on, so our thoughts were like this, that what would we have done differently? So sometimes you have a problem when you have wired the LED, if the proximal LED is very tight and the diagonal is very tight, if you do not have a good wire, you will face some difficulty in wiring the diagonal. And the patient can have a lot of chest pain, and you can think that what should I do? Should I just do the LED first? So the mistake that I think we made, we took a big balloon to dilate the LED. In afterthought, I mean, if I were to do it again, I would take a smaller balloon, just open up the LED a little bit so that I have a little extra room to pass the wire into the diagonal. And I would definitely protect the diagonal. And then proceed as we did. And I think we really underestimated the diagonal. We didn't realize how significant a vessel it was. So that is our case. I think I finished very quickly, so we can have some discussion.
Yeah. Thank you.
Yeah, actually, if you want to really save the diagonal, see, one thing in side branch is never lose it. Because if you lose it, you have a CK leak, and we know CK leak is correlated to long-term results. So have flow preserved. Like in the end, you have not stented it or anything like that. You have not polished it, but still flow is preserved. That's the final achievement. So here, sometimes if you're not able to wire diagonal, remove the LED wire and put it in diagonal.
Yeah.
Because presence of one wire in the main branch is hampering your passage into the side branch. I mean, in routine course, wiring that only diagonal is not going to be an issue. So you could have done that right in the beginning so that you save. Then before stenting the LED, since the diagonal lesion was almost looking very critical, it's like a subtotal diagonal. You could have just done a low pressure 1.5 dilatation, stented the LED so that the flow may may have remained.
Diagonal, I think it was very tight. I mean, we made mistakes, that I completely agree. We should have attended to the diagonal.
Just not your good day.
Not our good day.
But at the same time, if some of us face this problem when the patient is having chest pain on the table, had a recent MI, so you can't also wait for a diagonal to cross. So another tips is that you need to choose your stent again according to the distal vessel diameter. And maybe you can then proximal optimization, you can do the proximal stent, and re-entering the diagonal this time may be easier.
How did you cross?
Sometimes we feel that there may be some clot also propagated into the diagonal in this acute coronary syndrome setting. That is also a difficult thing.
Did you cross after pot, or did you cross after pot to LED? I mean,
Yes, we did pot. We did pot. So we stretched the artery open and then we recrossed it. Yeah, I mean, usually recrossing occluded vessels after, we don't face too much trouble. Especially the takeoff of this diagonal was not that bad. If it was really a right angle or a sort of like this takeoff, we would have been in a much worse trouble. But the takeoff was in our favor, so we managed to cross it easily. But I certainly, this is, if there are any juniors here, this is certainly not the way to do the case.
Actually, we took recently a case of mild changes in the inferior lead. It looks like RCA is the culprit. But in addition to those changes in the inferior lead, V1, V2 showed a clear-cut RV infarct. If you see, there was no RV branch seen at all on the angiogram. So we had to, because of that huge ST elevation which was indicating additional RV infarct, we first accessed the RV branch, preserved the flow, and then stented the, I mean, somebody could have completely ignored that, but that would have led to an RV infarct, which can lead to hypotension and so many other issues.
Dr. Pandey, how frequently you have used a double lumen catheter to enter this sort of complex side branch where you couldn't do anything?
No, I normally don't try with the double lumen catheter. Just try to enter in the side branch first, and best thing is you enter the parent branch, and while coming back it goes in the side.
Now
branch.
suppose the fielder XT fails and the patient is having still chest pain on the table, what you do, and you are not getting a flow. So, I mean, he succeeded, but after this, if you can't.
I would play around with the wire. I think you have to succeed. So if one doesn't work, I would choose another wire. I think in this kind of lesion, fielder FC also is a very good wire. And Xeon Blue also would be a very good wire.
Yes.
Now, a bigger question is like these sort of cases are not put into the trial, provisional stenting and a two stent. So very difficult to entry side branch. You should have a lower threshold for doing a two vessel stenting rather than a provisional one. That is my take.
You will do two vessel stenting in this case.
If it is difficult to entry the side branch from the beginning.
Yeah. I mean, but for that you would have to first appreciate, which we didn't, that the side branch is really significant. And our first mistake was we were thinking that the side branch was not that significant. But yes, if it is a big, you're making the point that if it is a significant vessel and you think that the ostium is diseased, then you could go for a two stent strategy.
Particularly if the entry is difficult.
Yeah.
Yeah, I mean, in this particular case, as he's putting it, we can always fix the side branch first after wiring and then go for the main branch. So two stent strategy, just to preserve the flow.
Yeah.
What happens
I
to it?
I wouldn't, I wouldn't stent side branches like this. I would go for a...
I mean, I agree that sometimes losing is bad, but just for that, putting a stent in a less than 2O vessel, I think it's not a good idea.
So one question, we have 1 minute. How many of you will try to enter this side branch and how many of you will just leave it like this if you face this problem? Those who want to cross, raise your hand. Okay, most of us want to cross. That's good.
You want to cross the side branch first? No, what was your question?
No. My question is, suppose you have not been able to get the side branch access after the stenting. You leave it just or you try repetitively?
No.
We must try repetitively.
Yeah, of course.
Yeah, Ramesh.
So I think it's a great presentation. Obviously, we learn all of us from our mistakes and complications. This is actually a very nice side branch because it is in line with the main vessel, as you said. But if the angulation is difficult, you have to try with different types of wires and different types of bends, reverse bend to get into the side branch. If you cannot, which has happened to me, I mean, as you said, ultimately you cannot get it. That is the worst complication that you can have. Patient has an infarct. You have to control the infarct. I have actually placed a balloon pump in those patients and gave adenosine as much as I can to the coronary artery to improve the flow, a little touch of maybe 50 mics of adrenaline to improve the flow as well in the side branch. If nothing works, actually, you have to control the infarction by giving a balloon pump or some device.
Thank you.
Just quick question.
Last question.
Hiramat, is there any relation between the stent size? What size of stent did you put?
3.
3, okay. So if you put 3 and 3.5, depending on the reference diameter, suppose the 3 is the distal diameter, you're putting 3.5, the propensity for the side branch closer and smaller size of stent and propensity for the side branch closer. Is there any difference in the stent size?
I think it's a
My thought is if you go for a higher size, there is more chance of branch closer.
Yeah, it's a very intelligent question. I don't think I have the wisdom, but I would also think the same way. If you use a bigger sized balloon or for that matter a bigger sized stent, the plaque shift would be much more, which would lead to more side branch occlusion compared to a narrow diameter. That's why the principle of POT is always matched to the distality of the vessel and dilate the proximal portion higher. That is the whole principle.
Yeah, that's the whole principle. Thank you, Dr. Bhattacharya. Bring hand to him. Thank you for sharing. The next speaker, please. Dr. Pandey, it's there. Dr. Rai, SB Rai, please. So before Dr. Rai start, the purpose of his presentation is that in this particular case, nothing has gone wrong apparently in the cath lab, but something has happened post-procedure. Am I right, Dr. Rai?
Yes, you
Yeah.
are very
Thank
much
you.
right.
Please go ahead.
And good afternoon, everybody. This is one patient, is 68 years old male. He had angiography 10 days earlier that elective angioplasty somewhere else, and he had recent anterior MI with ejection fraction of 50%, and echo there is hypokinesia only apical part. His risk factor was only hypertension. That means patient is very simple patient. This was his ECG before angioplasty. And he came for elective angioplasty. He was seen in outdoor and his pulse BP absolutely normal. And when he got admitted, then his pulse was 76, BP was 140/80, cardiovascular system normal, XHS normal, and hemoglobin was 11 gram percent. This was his angiography. That proximal LAD, some eccentric, 80% lesion was there. Then balloon dilatation was done and stent was put. And this was the result. There is no dissection either proximally, distally, or as far as we see, there is no wire-induced perforation. The angioplasty over by 12:30, and patient has shifted to ICU. After 1 hour, approximately 1:25 p.m., patient suddenly developed dizziness, hypotension and bradycardia. Then how to manage? His BP came down to 70, heart rate came down to around 40. Then this patient, what are the possibilities? After clean angioplasty, patient was shifted to ICU. Then it can be hypotension because of patient was fasting since morning. So on hypotension, sometimes vagal reaction can be there. Sometimes patient will be on a G10 infusion, and angioplasty related complication may be acute stent thrombosis, or maybe dissection subsequently happened, distal dissection particularly. It can be wire-induced perforation and later it can be tamponade. Maybe bleeding from the groin, retroperitoneal hematoma, delayed contrast reaction or drug reaction. These are the possibilities. Then after managing the patient, first thing we have to take one ECG to see whether anything going wrong or not. ECG is showing what was there before and after almost same. Then what will, as iatrogenic complication are always we are afraid of first to do the echo whether there is any tamponade or not. Echo there is no tamponade, there is mild diffusion and ejection fraction is normal and is LV also, this echo is showing LV improved. Ultrasonography was done, that is there is no retroperitoneal hematoma. Particularly what we are always concerned, there is no hematoma, XHS was normal, whether you have missed anything before that. Then after doing all this investigation, procedure related complication, you have to take the patient to cath lab. And first you have seen whether anything is there in groin or not. In groin, if you see that puncture was below the inguinal ligament against the head of the femur, and the classical point puncture was there. Then we have checked the coronaries. There is no distal dissection, there is no left main dissection, and stent was patent. We have seen the pelvis. Here we can see that in blood a dye is filled in one half and other half dye is not there. After seeing this one and there is no other complication, we have shipped the patient to ICU that there is no iatrogenic problem. So again we have repeated the ultrasound. In the ultrasound again, ultrasonal there is no retroperitoneal hematoma. Then at that time, patient was on dopamine infusion followed by noradrenaline infusion, IV fluids, pulse, BP was maintaining, but patient was still intermittent hypotension. Then what should we do next? Now, I think discussion we can done it here, but if now diagnosis will be clear subsequently.
Yeah, we can wait for a while and then quickly take up what we all thinking at this point. One
Was there a
sentence.
drop in hemoglobin?
So there is drop in hemoglobin was from 11 to 8.8.
So there is a significant bleeding going on. And the best way to diagnose is by doing a CT, if it is possible to shift the patient, or by ultrasonology, because sonologists are not very tuned to identify retroperitoneal. What I ask them to look for any perivesical collection, translucency. So that is the best clue to identify retroperitoneal.
The urinary bladder seems to be compressed.
Pardon?
Urinary bladder.
Yeah,
Urinary bladder seems to be compressed by a shadow.
Yeah.
That is a clue that he may have a retroperitoneal hematoma.
And had you approached it from left groin, or
Yes, I have approached from the left groin.
why not from the right? Was
Right
that-
groin, yes, that is a good question. He had angiography few days back
Okay.
from right groin. There was a hematoma that is not big, but some tenderness was there.
Okay. And have you made any attempt to take a venous access from left groin?
No,
No. So single arterial puncture.
single arterial puncture was there.
Right. So my diagnosis is retroperitoneal.
Yeah, yeah.
That is one diagnosis, retroperitoneal hematoma.
Could it be some delayed anaphylactic reaction? So
Yes.
Have you given adrenaline?
I have subsequently in management we
Adrenaline.
have to patient keep on adrenaline for 2 days, and then subsequently we are able to wean off from adrenaline. On third day morning we have weaned off from adrenaline. That is one more possibility. Then anything next?
No, I think CT and CT at this stage, you know.
Okay,
You must
sir.
do a CT.
Okay, sir, we will proceed. Then what we have done, we have sent blood for culture sensitivity, complete hemogram, CRP, procalcitonin, injection hydrocortisone 200 milligram TDS we have given. As Dr. Paja has mentioned that it can be delayed reaction, considering this one. And patient, in spite of adrenaline, non-adrenaline IV fluids, was intermittent hypotension. So we have to, as we know the coronaries are normal, we have to put the patient on IV adrenaline to sustain the blood pressure. Then, as we have seen, his blood hemoglobin dropped from 11 to 8.8. Total count has gone up from 24,000. His baseline count was there 7,800. His angiography was done few days back. At that time, it is that report. It has been in a short interval, and in between there is no temperature, nothing. Patient was totally okay. So second blood count has not been repeated, and his only hemoglobin has dropped. Count has gone up. His CRP, even on the day, CRP was normal, 0.35. CRP has not gone up, but his procalcitonin, and same day it has gone up to 10. And blood glucose was increased. This is because of adrenaline, hydrocortisone, may be related to that. At that time, there is no diabetes, but down the line after 3 years, patient developed diabetes. And patient was seeing that count has gone up, we put on piperacillin, tazobactam and targocid. Next morning, this was his ECG. ECG was improved, but on 10th morning we have seen, and that night as hemoglobin was low, we have given 1 unit of blood. Only one, just 1 unit, not more than that. His serum creatinine has gone up, potassium low, this thing all managed. On third morning, we are able to take the patient out of adrenaline support. Hemoglobin was 9.4, but we have not given any further blood, and count has gone up again. Then on 11th morning, that means after 36 hours, this count, neutrophil is 90%. This may be contributed to some extent because of hydrocortisone. He was on hydrocortisone or associated with infection. His creatinine started coming down and potassium normalized. So this is basically a case of septic shock. Septic shock with maybe minimal retroperitoneal, but as you have seen the groin injection, there is no retroperitoneal bleed. We have given the injection.
And you see the bladder shadow, it seems to be compressed.
We have seen the bladder shadow, we have repeated ultrasound twice.
On ultrasound, we have done the angiogram, and in the bladder shadow, urinary bladder, seems to be compressed.
Initially, it seemed this one, I thought also that.
Can you show that again, please, that bladder shadow?
Why you didn't do CT after doing so many tests?
Go back. Back. Back.
We can say half of the bladder is there.
No,
Another
there will be one. Show the one with the aortogram.
Aortogram.
Okay.
Not this. This one. Down.
This one.
There. Okay. It is the bladder. Yes, the bladder is
Bladder
compressed.
is compressed, yeah.
Yeah.
Bladder is compressed. Seeing this one, I also thought that it was retroperitoneal bleed. But repeated ultrasound.
This is a very abnormal looking bladder.
Definitely.
I have one question on the left. Sir, can you just, a cardiac shadow on outside, there is definitively a shadow. And possibly that may be a pericardial effusion. And at that time, the effusion, that is the injured vessel already clotted. Maybe like this, you see. Because septic shock cannot reduce your hemoglobin from 11 to 8 over a period of few hours. So possibly this is the effusion is the only answer. You see, just on the left side, that is not.
But he did echocardiogram. You did
Echocardiogram.
echocardiogram?
There is no pericardial effusion.
Minimal.
It is not. It is basic.
Mild diffusion is how much? 6 millimeter, 8
No,
millimeter?
that is just chink of effusion.
But here it seems to be more.
Angiography is not the correct investigation to say that it is pericardial effusion is there.
Yeah.
What is the incidence of bacteremia following groin puncture?
It is very, very rare. It is basically an endotoxic shock.
There is incidence of 4% bacteremia after groin puncture, and there is reported in journal that there is pyopericardium following groin puncture just after angioplasty.
Very good comments.
Yeah.
Yeah.
So anyway, I think you have rescued from the case, that's good. But all of us had a feeling that probably it may be a self-constant retroperitoneal hematoma, which automatically probably localized and it got infected. That's why you got a high creatinine count and it came down. Dr. Ashok Dutta pointed out also about the pericardial effusion, but anyway, you need not drain it, so it is unlikely it is a tamponade. Yeah, Dr. Kali, please.
Was there any growth in the culture? Was there any growth?
No, there is no culture.
That there was a drop of, hemoglobin by 2.5 or something.
No, not 4.5.
And then it followed by infection. So both were contributory, I think. There was some small retroperitoneal hematoma. And the best thing, as Shirish has pointed out, would have been a CT scan. We would like to know about the culture report, because if culture is negative, then probably it's not septic shock.
It is no, culture can be negative. But what happened, no?
See, Dr. Roy, the temporal course of events suggests bleeding, because you took the patient back and it happened very suddenly and soon after the angioplasty. So to diagnose this as septic shock so soon after, I think a more logical diagnosis would be bleeding, which got infected.
No, the septic shock is of the previous procedure.
Oh, okay. I mean, that is okay. You are diagnosing us. See, again, this is you are diagnosing septic shock occurring just after angioplasty from the previous procedure. I think, more logical is to think of retroperitoneal hemorrhage.
So we are surprised you didn't do a CT after going through all this.
CT was not done.
CT will absolutely pinpoint. HU unit will be more towards the external iliac artery.
And especially with the drop in hemoglobin. So there is a drop.
Suppose you diagnose it retroperitoneal, how would have managed this case?
If retroperitoneal hematoma is there, only among the all
Use the
cases,
microphone.
only around 15%, 15 to 16%, they may need operation. Rest of the patient can be managed with conservatively with blood transfusion and supportive treatment.
Sunip, your take?
No, I think time is over. But what we can do, we probably can do a DSA that will probably see if there is a leak. And a prolonged balloon dilatation is the most important thing. And check the APTT. I have never put a cover stent to stop the retroperitoneal bleed, and I don't think the surgeons are going to do anything. Dr. Iramat?
I think most of the time you will not be able to find a bleeder. So what you said is correct, that you just conservatively manage the retroperitoneal.
Yeah.
And so many times it's remote, like you do a radial procedure and you still have a retroperitoneal bleed. So it's not necessary that you're puncturing a iliac artery or anything like that. So I think retroperitoneal bleeding managed mostly conservative.
Mostly conservative, only 15 to 16% may need operation.
No, surgery is most of the time is never required.
Yeah.
In our experience, I have 3 cases in last 20 years, and the key is you diagnose very early, you 50% reversal of the heparin effect, and early sheath removal.
Yeah.
Your resident have to press the groin for probably more than 1 hour, but that did the trick in all the 3 cases and saved. By searching the guidelines, the recommendation is you do a opposite groin angiogram, find out the bleed, and do a balloon tamponade at the site of the leakage.
Yeah.
That's the recommendation. But in my practice, it's early recognition, early sheath removal does the trick.
How does early sheath removal help?
Yeah, because most of the puncture, which is retroperitoneal, is just above the inguinal ligament by few millimeters. So whenever you give a pressure, it relieves the tamponade. It avoids further bleeding.
Yeah.
So just pressing the groin and fluid and blood supplements does the trick, and it has done in all the 3 cases.
Thank you. Dr. Isbirai, please give him a big hand. And this is really a unique presentation. Dr. Mohanan, please you come for your presentation. And we are happy that something unusual we have seen. This is not uncommon actually.
Sudeep, I like the titles you are given. Were the titles chosen first or the case first and then the title was given, you know?
Respected Chair, thanks to the EIICCON team for inviting me. It's good to be back amongst friends and patrons. Well, this is again a case which was done about 5 or 6 years ago, but it's still relevant as the number of post-CABG intervention volume goes up, especially in our NIC data. You will see that it's just jumping up. This is the story of a 48-year-old guy with diabetic hypertensive dyslipidemic. He had an MI in 2008, not reperfused. He is a lorry driver, and he developed the MI during the way somewhere in Karnataka. They presented with post-MI angina. Angio done outside showed LMC and triple vessel disease. I didn't have the angio of that here. This was his revascularization, Lima to LAD, and venous graft to D2OM1 and PDA. He did very well for the next 3 years. Then he started developing symptoms, had an episode of unstable angina, and later an NSTEMI. Echo was showing a reasonable left function. This was the time when he had that NSTEMI showing multiple leads showing significant ST depression. It was reported again that he had an unsuccessful PCI to the RCA. We have no details on that. When we came to us, this was the angiogram, not very sure whether you can see it very well, but it showed significant lesion of the significant native triple vessel disease, distal LMCA, ostial circ, showing significant disease. And this was the RCA which someone has attempted, and but that showed a diffusely diseased RCA with a mid RCA showing significant narrowing. So that was the Lima, if you look at that, looked decent, but the distal flow was not that convincingly. Even though we took multiple views, we were not much impressed by the distal perfusion and the LAD. We couldn't cannulate any of the venous graft. So before deciding on anything, so this was the impression. All the venous grafts could not be, obviously they are blocked. Patent LAD, Lima to LAD, but we were not very sure about the distal flow in the LAD. So we did a 64 slice CT just to assess that we have not failed to hook the venous graft and they are still flowing. So this was the CT report, CT angiogram report. And then we thought we will go ahead with a PCI because as you know, a repeat CABG was absolutely not acceptable to him. Do a syntax score post CABG has any relevance? I don't know.
No.
Maybe you can, yeah. But these were the days when we didn't have any imaging at that time, about 5-6 years ago. Of course, the patient had increasing angina and he didn't want to go to anywhere else. So our strategy was to stent LMCA to LCX. I didn't think that RCA was the good choice. So we went with that. We dilated the LMCA to wired both LAD and LCX with a BMW and a floppy wire. Dilated the LMCA to LCX with a 2 and 2.5 balloon and stented the LCX from LMCA to LCX with a 4 to 20 stent. Things looked okay, and I thought we will stop short with that. But 3 of my colleagues who doesn't have gray hairs like me were aggressive, saying that we should do something about it because the CT picture, the earlier angio picture, showed that, well, why don't you tackle the LAD also? I suppose the best way to resist a temptation is to yield to the temptation. So I yield to the temptation, and we went on. We thought maybe a tap was the best thing to do. The bifurcation strategy, dilated the LAD, and then tried to stent it with a 3.5 17 millimeter. That was the days of the biomime stent. That was the stent used. So with the deflated balloon in the LCX, we stented the LAD. And that showed, okay, I mean, we needed, of course, we needed a SCASE and be a final port. We were planning that when this occurred. He arrested, and we have no clue what caused that. There was no significant no flow and there was no dissection. Of course, in our back of mind, we had this nagging doubt of, well, you have a perfusing lemma and then you're trying to do, is there the flow dynamics, are you going to sabotage the flow dynamics? That was always in the back of the mind. But somehow, God forbid, we salvaged the situation. We again dilated both the LAD and the LCX. Individually dilated it and did a simultaneous kissing. And this was the final result. This looked acceptable result at that time. And this was, I mean, he remained symptom free. He is a container lorry driver and was very worried that he will not be taken back for his profession. And then he refused any further coronary angiogram. So we told him, why don't you do a CT angio this is after 3.5 to 4 years. And of course, this is not the best way to image the coronary arteries, we know that, but this looked okay. He remains asymptomatic, still continues to get a follow-up. So that was the story. I still don't know, maybe my expert panel will be able to me an answer. What is the importance of flow dynamics in a post-EABG patients? Was that totally unnecessary intervening the LAD? Of course, we have been discussing right from the live cases, we have been discussing the LMCA strategies, but post-LMCA strategies, we don't have too much of data. Of course, we have the syntax 5-year data and of course, the Noble and the other studies, the Resolute all-comers data. But this is some of the points which possibly we can discuss if the time permits. Thank you very much for your...
Thank you. Thank you. Thank you. Excellent. We quickly take up the
Mohan, I feel your flow from Lima to LAD, yes or no, was a very crucial question. According to you, it was okay. CT
I
was
thought it was okay, but my colleagues thought...
No, but CT was saying it was okay. CT also showed it was okay.
It also showed some suspicion.
So I was actually wondering why, if you had to put a stent in the LAD, the stent should have gone from ostium of LAD into diagonal, and you have allowed the Lima to perfuse the remaining LAD, because diagonal is also a very big sized vessel. So that's one deviation I would have done and stented towards diagonal, because LAD is anyway getting perfused from Lima. I would do it, yes. It was heavily pitched artery and it was a big circulation.
So what was the reason for the asystole actually? So that's also suddenly, I mean, unexpected. There was no air and ACT was normal. The flow was also...
But is it criminal to, let us say, if the flow is decent and still you have a blocked diagonal vessel, will you still dilate, put a check in the diagonal?
I mean, I always like to compare myself with a surgeon, you know, how much he would have revascularized. And if we can come to that level, then only we are talking shoulder to shoulder on our results with them. So generally, I would like to revascularize more completely in these kind of situations. I mean, they can't come back again and again. So you revascularize this more completely.
No, the logic of LAD stenting should be dependent on the Lima flow. If your Lima flow to the LAD does not show proximal perfusion of the diagonal branches and septal branches, then you need to intervene from left main to LAD. But if your Lima shot shows that your LAD is filling right up to septal 1, nothing needs to be done from left main to LAD. Sure. Just fix LAD left main to LCX.
No, it cannot.
Hello, I'm here. Like post-CABG coronary, it's totally different from the native coronary, everybody knows. What the mark is lying there. There is no flow for last 7 years or 8 years, whatever the CABG duration may be, because there is no flushing in the proximal LAD. So if you do the IVAS in those cases, you'll see a lot of mugs, I mean a lot of cholesterol, debris. So I think it was stunned myocardium. Once you put a stent, and Hidemath is absolutely right, if you have a Lima flow, the LAD, you have to put the other end of the stent in the major vessel, not in the LAD, because the LAD will not flow. So you have a flux of the stent in the LAD, that is number one. Number two, if you're putting stent in the LAD, actually throwing all the mugs into the distal vessel. So it was a stunned myocardium.
Thank you. So, Dr. I really, Dr. Bhattacharya, don't know why you get a asystole after this stenting. I mean, that's really a question mark for me.
Yeah, difficult to say. Difficult to say. The only thing about your case, sir, was that the distal vessel, when you were doing the Lima, we couldn't see the distal vessel very well. And also, as you said, your CT angio also didn't show the distal vessel very well. So that is a little concern, because strategizing is difficult. So you are going in slightly blind. And the other thing is that the whole angioplasty was done only in one view. Yeah. So we would have, I think, probably had a better idea if there was at least another view, maybe a epicranial or a eleocranial view.
The LAD was seen in multiple views, and it showed every time we were worried about the distal LAD flow.
No, during the angioplasty.
Okay.
During the angioplasty, it was all eleocaudal. So that is, and I have no clue why you had that. Sorry, I don't know why you had asystole.
The other thing is when you're checking internal mammary, also check the subclavian. Sometimes these people develop narrowing at the origin of the subclavian, which may be angina giving.
classic subclavian steel. That
Yes.
is very well known, but
Yeah.
this was something which was
Yeah.
not known.
But you did a good kissing at the end.
Yeah, we did a final
That-
kissing.
Because at that time you didn't have the IVAS and all this
No,
thing.
we never had any imaging at that time.
Yeah, thank you. Yes, Ramesh.
Sorry. So, I mean, I think cause of asystole, there are lots of things, stunning from air embolism to anything that we can think of. But, these things happen. But most of the time, as you're saying, if you had listened to your own voice, I'm sure it would have been avoided. You would have left the circumflex to left main stent and then we would have brought him back and he would have been willing to go ahead. So whenever I had a problem, my complications were when I thought, oh, this went very easy. Let me go ahead and do one more procedure in the same patient and not listening to an inner voice, which actually is probably better judgment that gives. We have seen asystole, but being prepared for it is the most important thing which you did successfully. Thank you.
Sunil,
Thank you.
we haven't discussed Dr. Hiremat's case.
Yeah, so, Soumitros, just, sir, I have only 2 points to know. That 2 points you say that how you avoid a problem related to the rotor wear. Second is how you predict and prevent stuck rotor bar. Maybe that will be the best thing what we can answer.
Yeah, actually, most of us size, I'm answering your second question first, how you avoid stuck of the burr. Most of us size the burr size to the diameter of the vessel. Like we take 66% of the diameter of the vessel. So if a vessel is 3.5, we would take a 1.75 burr and things like that. That's the first burr. But if we take a smaller burr based on the load of atheroma or load of calcification in that area based on any kind of imaging, angio or IVAS, you'd probably burr smoother. It would avoid the slow flow, no flow phenomenon, also avoids stuck burr. And then you go to a bigger diameter burr. I think this is the way I would probably avoid the stuck burr. But stuck burr is very dangerous. I mean, it's not like a balloon not coming out and you jam it and it comes out. Stuck burr can really tear the artery.
Okay, so can I ask 2 questions, maybe 3 questions? So what do you do with your rotor fluid? Do you put anything in it?
Oh yeah, of course.
What, heparin and nitrates?
Nitrate, calcium blockers.
And calcium channel blocker.
We have diltiazem in that.
Okay, and what platform speeds do you use for a 1.25 bar? Rotor speeds.
Oh, we first check with, standard checking is 160 on Dyna, and then we go to 180 as our regular speed.
Okay, and do you use intravascular imaging in all your rotor cases or?
Most of them, yes.
Okay, thank you.
Thank you all. So, sorry, Soumitro, we are running late a little bit. So, I congratulate everybody for their excellent speech and thank you for your participation. So,
Thank you very much to all the presenters and the experts.